Thank you, everybody, for being here. It's a real pleasure to have this opportunity to join you and to be on this program that's sponsored by the Georgia Global Partnership for Telehealth. GPT has been active in RPM, and with our OEM partner now has deployments to over 2,000 people. And RPM is growing very rapidly, and it's absolutely something that when you think about patient care and chronic care management, it should be high on your radar. Let's see if I can master the technical parts and share my screen. There we go. Uh, how's that? Good?
Perfect.
Terrific. Well, I don't know if it'll be everything you need to know about remote patient monitoring. However, it will hopefully be enough to lead you to where you need to go. And we are very excited to be here as a resource for you. So first, let's look at why remote patient monitoring or remote physiologic monitoring is so popular, why it's growing, and why CMS has decided to reimburse it not only for Medicare, also now federally qualified health centers and rural health centers can bill separately for remote physiologic monitoring, and many private commercial plans are now billing reimbursing for RPM. The reason is that there's an epidemic of chronic conditions in the United States. 60% of adults have at least one chronic condition. Up, wait, we've got a poll. I'm sorry. So let me put that in there.
Poll is live. Go ahead and please answer your questions.
Thank you, Salima.
Just a couple more seconds.
Yeah, absolutely. I was so excited, I forgot we were doing a poll. Sorry about that.
Okay. I wasn't sure if it would show while you were talking, it wouldn't distract you, but it popped up, so my apologies.
Oh, no, that's fine. I'm glad that it did.
All right, I'm going to go ahead and end the poll. So many of them currently operate an RPM program.
Okay. All right. So why is RPM so popular? The reason is that we have a chronic condition epidemic. 60% of adults have at least one chronic condition. Adults have two. 10% have five or more, and just that 10% represent 41% of all healthcare expenditures. And in fact, something along the lines of 80 to 90% of the $4 trillion that is spent on healthcare in the US each year goes to chronic care management. So the cost of caring for these folks is large, and it's continuing to increase. And anything that can help us improve their outcomes and manage those costs, as well as make things better for providers, is really hitting upon the triple aim. And now, of course, the quadruple aim, which is provider safety. Okay. Is RPM effective? Absolutely. Geisinger Health Plan reports that its use of home telemonitoring program for patients with congenital heart failure reduced their readmission rates by 44% compared to a control group. As part of post-acute care, RPM systems can keep admission rates low in the first 30 to 90 days. For example, patients with CHF using RPM had a demonstrated 50% reduction in readmission rates, according to a nationwide readmissions database. 23 million people used RPM in 2020, and that number is expected to be 30 million this year. There is a growing body of clinical literature that demonstrates that RPM is very effective in scaling care. You can see that in these growth rates. RPM is growing very significantly in terms of the number of people being monitored. You can see on the right side, the primary conditions are diabetes and heart disease. There are other conditions as well, However, it's no coincidence that those are the two largest chronic conditions that people are being treated for, and so they represent the populations where the biggest impact can occur. And one of the things I want to mention about RPM is that similar to chronic care management, which many of you are probably familiar with and may be doing, RPM relies on collecting information over time. However, RPM is very, very distinct from chronic care management because RPM is objective data. Its information is collected using devices. It goes into a database or a cloud storage um, database, and using algorithms and artificial intelligence, we get very objective information about how people are trending. And that is the reason it's so effective. CCM is effective, although it is very subjective because it relies on a phone call with the patient. So RPM is an evolution of chronic care management. And it is really one of the first places where we see that technology can be used very scalably to make a large impact. Who is eligible for RPM? Any patient with at least one chronic condition or an acute illness that warrants RPM services, and you saw that list on the prior slide. Active Medicare folks are eligible, as are people who are on a commercial plan that covers RPM. Medicare Advantage includes RPM, and many private plans are also including RPM now. The only requirement is that the patient have an established relationship with the billing practitioner. There is not a diagnosis because their condition is already diagnosed. However, an order does have to be written.
Boy, there's two questions specific to your slide right now, asking for you to define CCM, and then what were the illnesses that fall into the RPM category?
Sure. Well, chronic care management is a program that has been around for quite some time. In fact, as has RPM. Chronic care management typically involves one call per month of, I'm not quite sure of the exact time, but I think it's 20 minutes. And so what typically happens is that a medical assistant will call the patient, say, how are you doing today? And make a note of that in the chart. Now, what tends to happen is that however the patient is feeling at the time on that day will become whatever goes into the chart, whether or not that's indicative of the patient's, excuse me, condition over a 30-day period, or if it's not indicative. So it's extremely subjective. It is, however, and was and continues to be a big step in the right direction because we know that moving healthcare from episodic care, visits in the office, to more longitudinal care where we really get out in front of trends and intervene before patients have significant exacerbations is really the way to keep folks out of the emergency room. It's the way to keep them from having these acute episodes. So chronic care management was designed to address that. And RPM, which is now really possible due to the widespread use of Bluetooth and cellular, and also safe, HIP compliant, scalable healthcare clouds where information is collected, has made RPM possible. And I'll go back one slide here. You can see these. This is a list of conditions: hypertension, sleep apnea, um, obesity, diabetes, heart disease. Others include mental and behavioral conditions qualify, and a range of other conditions also qualify. So RPM is, per CMS, intended to be used on a very broad scale. It's why in 2019, CMS decided to make RPM reimbursable, and it's why you've seen a proliferation of RPM. And again, it's really distinct from chronic care management because, as we'll look at in just a moment, RPM is collecting a series of measurements from the devices at least 16 times a month. And that's going into a healthcare cloud where algorithms and increasingly some smart artificial intelligence can monitor that. And that is so much more effective at predicting outcomes and predicting exacerbations than a once-a-month call. So hopefully that answers that question. It's a very good question. And in fact, I would point out, really importantly, that chronic care management is not being replaced by RPM. CCM, in fact, can be done along with RPM, and the same patient can receive RPM care and CCM care in the same month, and both of those are reimbursable in the same month for the same patient. The benefits of RPM we've talked about, but really it's bringing care to the patient's home, which minimizes the shortcomings of episodic care. So one of the big challenges with chronic care management is that many patients, just due to availability of providers, their own ability for transportation and managing their care, fall into sort of the least common denominator of care. So if it's going to see their provider every 90 days or every 6 months, then that's what they do. However, as we all know, patients are different, and some patients with, say, diabetes might be just fine going to see their provider once a month. Their A1C levels are stable, their medication regimen is stable. However, someone else may need to see a provider once a month or every 2 weeks. But how do you know that if the patient isn't in communication with the provider? RPM enables that communication to happen from home, and it removes that episodic care sort of thing where someone comes in, they go into the ER because they're having an episode, or they show up at their provider's office, their PCP's office, and they've really shown a decline. Longitudinal care, consistent care is really the way that we can improve the outcomes for these folks. RPM provides visibility into condition management between visits and allows for timely intervention, which is what we just talked about. And very importantly, we see increased patient engagement and treatment compliance. So if a patient, and I would add their care team, often it might be a family member or someone who is not on the medical clinical team, but is part of that person's personal circle, is very engaged in care. And RPM typically allows members of that care team to see the results that are coming in from that patient. So if my mom's A1C levels are really starting to vary, I can see that. I can log on every day and I can check the portal and I can see how she's doing. So it really gets everybody engaged. And there's data that shows that when patients have more access to better data, they tend to be more engaged in their own treatment. And so there's a whole bundle of benefits, a whole bundle of reasons that RPM is so effective. But what exactly is remote physiologic monitoring or remote patient monitoring? It is the passive collection and transmission of vitals outside of the clinical setting to notify the care team of concerning alerts, and 20 minutes, at least 20 minutes per month of analysis and remote patient consultation by a qualified healthcare provider. And what you see are that list on the right, per that earlier question: hypertension, diabetes, COPD, weight loss, heart conditions, sleep apnea, asthma. Those are all conditions. It's not an exhaustive list, but as you can see, it covers the vast majority of people with chronic conditions. And you can see that middle column is what is being monitored. So what that really means is that patients have devices. They are most often now connected to a cell network. There was a time in the not so distant past when people were trying to connect to Wi-Fi networks and things like that. That was very problematic. These devices collect to a cell network. They have their own SIM card. They have their own connection. And when a patient uses the monitor, whether it's a pulse oximeter or a glucose monitor, a continuous glucose monitor, a weight scale, the data is automatically transmitted via a cell connection up to the health cloud, where it goes into their record. That's the first part of what RPM is, and the requirement is at least 16 times per month. The second part of RPM is that a qualified healthcare provider must spend 20 minutes per month reviewing that chart data and communicating with the patient. Now, that might be 15 minutes of reviewing the chart data and 5 minutes of speaking with the patient. Excuse me. Or it might be 15 minutes of speaking with the patient and 5 minutes of reviewing the chart. Very often, by the way, that is a managed service, which we're going to talk about in just a minute, where it is outsourced by a clinic or it is outsourced by a practice, and they receive notifications when there's an exacerbation. However, the bottom line is that it's a collection of 16 readings per month and 20 minutes of time spent doing analysis and communication. By the way, that communication is typically done via telehealth. That is very convenient for the patient, it's very convenient for the provider, and it allows for a great deal of scale. And that managed service approach also allows for a great deal of scale. What we very frequently see is that a clinic or a practice simply does not have the staffing and the resources to manage this themselves, but a qualified provider can do it for them. And I would emphasize that this is not personal emergency response, right? This is not, I've fallen and I can't get up. This is preventative, it's proactive. And so most of the patients in these programs are not going to have urgent episodes. It's only when their readings are outside the parameters that have been established for them that their healthcare provider will be contacted. These are typical devices that are used for those conditions that we talked about: glucometer, blood pressure cuff, thermometer, pulse oximeter, CGM, weight scale, and very critically, a cell hub. Typically, with the best programs, a cell hub is included so that it's simply plugged in. It connects to various cell networks using what's called a super SIM card. And these devices, when a reading is taken, they communicate to that cell hub and it's sent up to the health cloud. And AI is increasingly being applied to this. It could be very challenging, almost impossible, really, for a person to go through on a daily basis and look at hundreds and certainly not thousands or tens of thousands of records. However, AI is very good at that. It's exactly the kind of thing that AI is good at, something that is very repetitive, that requires scale, and that is very data centric. So AI can immediately start to see if there's a trend over the last day or two among thousands of patients that is alarming. And those parameters for each patient are also personalized. So it's connected devices, AI enabled, using cell devices to connect to the cloud, taking 16 measurements a month, and with a provider following up. Wearable monitors are also a super interesting and important development in this area. So we do have the challenge that mom still has to use her glucometer to get that reading in. Now, I can bug her, but sometimes she doesn't really pay that much attention to me. So for certain conditions, wearable monitors are really helpful. They empower the patients to take greater responsibility for their health and care. They provide continuous real-time data, and improved self-monitoring and healthy habits are encouraged, such as increased daily activity. Most of these wearable devices are on the cusp of receiving FDA approval. Some of them have received FDA approval, others are in the queue. What you'll find with best practice programs is that wearable monitors are included. And while they can't necessarily duplicate everything, they can duplicate many things and in terms of readings, and they also provide corollary readings that, again, with an AI powered system, is really able to look at and understand if there's reason for concern. So wearable monitors are a very important part of the program, and if you're looking at a program, be sure that you look carefully to see if your provider includes that.
Would we want to go ahead and go to the next poll question?
Yes, please.
Okay, the poll is now live.
Thank you for that reminder.
Boyd, can you see the results?
I can.
Perfect. Okay.
We have a lot of other. Yeah.
If you guys don't mind typing in if you'd like what type of organizations you're with, that'll be super helpful. But thank you so much for completing the poll.
Thank you. Are we ready?
Go ahead.
Thank you, Salima, and thank you everybody for completing the poll. Key considerations in launching a program. I'm going to go through this pretty quickly. I'm going to hit on the high points. However, these are really the critical things to think about. Keeping in mind that what you would really want to be doing here for your patients is creating a smooth transition of care, especially for patients who might be in acute care, who could be transitioning to rehabilitation, and then could be transitioning to home. Maybe it's a hospital at home scenario, and the goal is to ensure that that same level of care, that same level of surveillance that, or close to it, that they received in a facility is continued in the home environment so that you don't see them back in the ER, right? Nobody wants that. That's not good for the patients. It's not good for the staff. It's not good for the patient's family. So really think about RPM as a link in the chain for moving from episodic care to longitudinal care. And as such, when you are looking at your program, you really need to ask yourself, what are my clinical goals? Which conditions do I want to manage with RPM? If I'm a cardiologist, obviously I'm going to be managing heart conditions. If I'm a primary care provider, maybe I have a large percentage of my patients that are diabetic, and I might want to really focus on patients with diabetes. What are your goals in terms of success metrics? Do you have baseline measurements? How are you going to set the measurements for your various patient population? How are you going to talk to your patients about the program? How do you intend to enroll them in the program? And while this might sound a bit overwhelming, that's where the managed service providers come into play. And I can tell you from working as we do with a fair number of health systems and hospitals, it is the norm for practices and hospitals to work with managed service providers to take care of most of the logistics and reporting, because your staff is already overworked and it's probably not feasible that your staff can take on a scalable RPM program. So really understanding your goals. What are your clinical goals? What are your patient goals? Do you have information about which patients are most likely to adhere to the program? How do you set that criteria? Eligibility verification, insurance verification. One of the things that we typically recommend is that you start with Medicare patients, because Medicare does reimburse for remote patient monitoring, and very often those older patients with chronic conditions are on Medicare, and so that can be a good place to start. But really understanding your goals. Do you want to start with a pilot? What patient types, success criteria, etc. That's crucial. The other thing is provider engagement. So RPM does not require a specific diagnosis, but it does require an order from a physician or qualified healthcare provider. And for RPM to be successful, your ordering providers must be engaged with the process and buy into the value of RPM. Typically, you want to have a provider who is a champion of RPM. If you have specialists, again, someone who's focusing on cardiac conditions or an endocrinologist, they're going to be more likely to be champions of RPM because they're dealing with those conditions that can really benefit from a remote physiologic monitoring program. The third point, staffing resources and managed services, which I've mentioned a couple of times. Your internal goals should also factor in an honest evaluation of your staffing resources. Unsurprisingly, one of the prime reasons that we see RPM programs struggle is lack of staffing. The success of an RPM program is really dependent on the ability of clinical staff to build trusted relationships and meaningfully engage with clients. That is really essential. And when you have a staff that's probably already working at 110 or 120% of capacity, bringing a program like this to them and asking them to do it is pretty challenging. And that's why managed services are so important and such a good option for so many people. Again, you typically want to have a provider champion. You want to have an RPM lead who's going to work closely with your RPM partner. Onboarding staff is really critical. A managed service provider can help with that. However, there's the whole process of shipping devices, logistics, scheduling, and going through the onboarding process of getting patients on board. There's even an upstream component of that of identifying parameters, because not every patient's parameters are going to be the same. And one of the highly effective capabilities of an RPM program is that one person's blood pressure variances may be significant, while another's may not be significant. That can all be put into the system and managed accordingly. A good RPM managed service provider is going to provide logistical services. That includes shipping out the devices. It includes device setup. It includes the call and the scheduling. So partner selection, number 4, is really crucial. And when I've talked about managed services, I'm really talking about partner selection. Software considerations with your partner is absolutely crucial. We've seen systems where they look very good for the provider, they work well for the patient, but for example, there's no ability for the patient's personal care team to be able to see the data. That's a real shortcoming, because I want to see my mom's A1C readings. I'm more likely to be tracking them than she is. Of course, we're all super aware of security. So are you working with a partner who is HIPAA compliant, who can meet all security requirements? From the provider perspective, you want a portal that if a provider receives a notification, that they can easily go in and look at that information. For example, if one patient has a weight spike that indicates an exacerbation, and the managed service provider's qualified health provider, typically a registered nurse, recognizes that as something that should be flagged to the physician. How is that flagging done? Is that a message that's sent through the EHR? Is it a text message? Is it a phone call? All of that is understanding the software consideration of the RPM provider's platform. Customer success and customer support is crucial. That means working with patients to get their devices set up, to get the device shipped out, to respond to the patient if there is an issue, if the device breaks, if they drop it in the swimming pool because they were there with their kids or something. How quickly is another device sent out? The managed service component. Do you want those patients who are simply having trouble maybe getting their device to work right, calling your practice, your hospital? Not really. You want them to call the managed service provider to take care of that problem. So patient uh, support, client support is really crucial, and you want to verify that partners that you're considering provide really good services. Another really key consideration in partner selection is managing patient adherence and engagement. So what happens if the devices are sent to a patient and they stop participating? They participate for a few months, or they're getting 14 readings a month, but not the required 16. The partner's system should have the capability to automatically monitor the number of readings that are coming in, and if those readings fall below the minimum required, the managed service partner should follow up on that. And that is scalable via a good, robust software platform. that is super important, and it relates to various financial models that you'll see. Um, so who pays for this? Who pays up front? Who pays on the back end, etc. There are various models. So one model would be that a practice or a hospital takes all of this on themselves. They buy the devices up front. They typically are going to white label a platform. They assign their own staff to manage all of this. And as you can imagine, that is a considerable amount of expense. We worked with one program that launched, one hospital that launched a very successful program. They have, however, had to bring on 2 FTE registered nurses to manage this program. They are paying for the devices up front, and they're paying for the shipping. And as such, while they've had very good success with patient adherence and engagement, they've had very good success with health outcomes, they are losing money on their RPM program. Because of that approach, because of that model, the managed service model has become increasingly popular. The managed service model is in its fullest incarnation. I'm going to talk about the full chain and then the ways you can back off from that. The fullest model is that a managed service provider takes on the cost of sending the devices to the patient, takes on the cost of setting the device up, calling the patient, making sure those logistics are handled properly, takes on the cost and the work of receiving the monthly measurements that come into the system. They take on the job of monitoring those and doing the outbound calling to the patient. And in its fullest extent, they can also take on the billing. And really, there's very little for the hospital or the practice to do. And in that case, the managed service provider would simply send a payment to the hospital or the practice or the clinic at the end of the month. Now, that can be broken down into different pieces. And one of the first things that tends to stay in-house is the billing. So often what happens is the managed service provider will simply do all of those other things and send invoices and with CPT codes or G codes to the clinic or the hospital, and they will bundle those into their regular billing. That's pretty typical. Another place that you see variance is on how the devices are paid for. In some cases, the practice or even potentially the patient is required to pay for the device right up front. And then as soon as claims start to be submitted, the hospital or practice starts receiving payments. In other cases, there may be no charge for the device being sent to the patient. However, the managed service provider will recoup that cost over the first 90 days. And only after 90 days will payments then start to flow to the practice or the clinic. Another place where there's variance is on who does those follow-ups. So as you'll see in a moment with the CPT codes and for that matter with the G codes, there's at least one 20-minute encounter per month. Who does that? It can be the clinic staff or it can be the managed service provider. Often we see clinic staff start to try to take that on and then realize it's too much. So you see people setting these up with different financial models. The program launch, excuse me, is also crucial. Excuse me. Sorry about that. Program launch and maintenance is crucial. So which device will the patient be sent? How long will they be in the program? You can typically break a program like this into various components. There's the planning component, defining what your clinical goals are, defining what your patient goals are, training your staff to work with the managed service provider. Go live. If you're ultimately going to have, say, a program with 100 patients or 200 patients, how do you roll that out? You initially do 25 patients and then the balance. Do you do a pilot first? How are you going to manage all of that? Patient monitoring is also crucial. Who on your staff is going to receive the notices that when there's an exacerbation or a call needs to be made? And growth. If you're successful in your first 100 patients, are you going to grow to 200 patients or 300 patients? And what is the process for growing and maintaining that program? We actually have a pretty extensive checklist at GPT that we can take you through to cover all these things. And let's see here. Talking about reimbursement. Obviously, this is very critical. And we'll talk about FQHCs and RHCs in just a moment. For standard CPT billing, there are really three codes that are crucial: 99453, 99454, excuse me, and 99457. The 99453 is billed one time, and that is typically billed by the managed service provider. That is shipping the equipment to the patient, that is getting the patient set up with the equipment. The collection of 16 readings per month is the 99454 code. That is the collection, transmission, and reporting summary of the services to the clinician. 99457 is the 20 minutes of engagement over a 30-day period. 99458 is a second 30-day or 20-minute engagement over the 30-day period. So what you'll typically see with 99454 and 99457 is that is $94 in reimbursement. A managed service provider will charge you less than that to manage the devices, manage the collection of information, and engage via best practice is through a registered nurse with that patient. So let's say a managed service provider RPM partner were to charge $65 per month, and through 454 and 457, you're billing $94. That is an additional almost $30 per month. And for a large practice, you could easily see that they might be up to 500 or 1,000 patients over time. That's a really significant amount of revenue. Approximately 50% of patients also require a second call, and that's the 99458. So now the reimbursable services being provided are over $100 per month, while the practice might be billed somewhere between, by the provider or by the RPM partner, $60 to $70 per month. So this is really a great opportunity for revenue generation, in addition to reducing return visits to the ER, in addition to really providing better health outcomes. So the 454, 457, and 458 codes are the ones that you're going to be dealing with on a regular basis. And if you do choose a managed service provider, one of the most important things that you're going to need to consider from a financial model perspective when it gets back to that software system is is that system going to send to you at the end of the month detailed information about when the dates that that information was collected, that meets the 454 criteria? When did that interaction with the patient occur? That's the 457 criteria, as well as the 458. It's really crucial that your managed service provider get you good information on that. Now, as many of you may know, just starting in 2024 for federally qualified health centers under the G code 55011, now RPM can be billed along with uh, principal care management, behavioral health integration, and chronic care management. FQHCs were not able to do that before, and now they can. So that's a great opportunity for FQHCs, and their populations also tend to benefit greatly from these services. And I would add that for these standard CPT codes, a practice can still continue to bill for CCM and as well as other services like BHI and PCM. And some of this can all be done at the same time. So this is really a great opportunity to provide better care for patients, provide better outcomes, and to generate revenue for a practice. And that's why you see really rapid growth in remote patient monitoring. GPT is an RPM provider, and we encourage you to look around. We think a knowledgeable and educated client is the best client. We would strongly recommend that you do a checklist when evaluating partners and look at these things. First, is it a flexible startup fee structure? For example, do you have to pay for the devices, or can the device cost be deferred so that there's no upfront cost for the practice? Scalable logistics and shipping. Is it a partner who can demonstrate that they have a track record of shipping hundreds, if not thousands, of these devices and success in setting them up? Can they demonstrate to you how easy it is to set these up? I've done it myself, and with the program that GPT is offering, it is literally a 5 or 10 minute kind of setup. Cellular connectivity is crucial. So a cell hub or something similar to it, so that your patient's not reliant on a Wi-Fi connection. High reliability data and reporting platform. We've talked about that. A 360 care team dashboard that, again, and we've talked about that. Can the provider see the views that they want to see? When you're evaluating a partner, you should see the provider view. You should see the care team's view. You should be able to see the patient's view. You should be able to look at patients by grouping, by geography, etc. For Medicare, a US-based nurse call center is required. Insights and data-driven intervention. When there are exacerbations, when people are falling outside of the parameters, what is the process? What is the workflow? Is it scalable? Clean billing and claims submission. We talked about that a minute ago. You don't want to put all this in place and then find out you're getting data out of the system that doesn't enable you to really submit clean claims. You want those clean CPT codes, you want dates, you want exact procedure information. Regulatory compliance, is everything being done in a HIPAA compliant fashion? And then finally, stellar customer service. And I can't emphasize this enough. Nothing is perfect. So what happens when the dog chews up the patient's pulse oximeter and they need it right away? How quickly can that get back out to the patient? For some reason, something happens with billing. How quickly is that RPM partner going to get back to you? Stellar customer service is crucial, and we really encourage you to go through this best practice checklist. If you would like more information, we have a couple of things that I think might be interesting to you. We have a detailed RPM billing guide, and if you'd like to just throw your email into the chat, we'd be happy to send that to you. If you are a federally qualified health center or a rural health center, you now have a tremendous opportunity to put these programs in place, and we've created some specific guidelines for that. We would be very happy to work with you. We think that this is a very important opportunity. GPT has been providing virtual care services for over 20 years, with a real focus on nonprofit, a focus on rural populations, really with a mission to bring healthcare to those who historically have the most trouble accessing it. And often those folks are the ones that are dealing with chronic conditions. And so we're really excited as part of a continuing 20-year mission to bring better healthcare to people through these virtual programs. So please contact us. Let us know if you'd like us to send you this information, and I will wrap it up.
Thank you so much for that, Boyd. We have several questions, so I know we're limited on time, so let me see if I can get through some of these. I see one that says, I'm with a practice management and consulting company, and we have been getting a growing number of inquiries about the copay and some about coinsurance. Medicare Advantage plans seem not to cover the patient's copays each month. Is that not a CMS regulation that they cover?
That is a great question. So Medicare Advantage does cover RPM. The copays can vary. The device itself, though, is that's paid for, right? Those devices are not very expensive, so that should be paid for within a very short period of time, and the copay should be minimal because Medicare Advantage does cover these programs. If there's a copay for data collection, that's a different issue, and that would be specific to the plan.
The next question is, what is the best source of efficacy data, and where is the best bibliography maybe to search for?
Yeah, that is a great question too. I would be happy to provide you with that. There is a whole range of data over the last 10 years. I mean, you can go um, and do a search for scholarly and clinical articles, and really what you'll tend to find is that it's by specialty. So, for example, one of the things that we cited in the beginning was for congestive heart failure, or you'll find things for diabetes. So that's really tends to be the approach. So depending on what you're looking for, we'd be happy to get some information to you. But it's if you do a little bit of a search, you'll find plenty of information.
The next question says, how long does it take to launch an RPM program?
Yeah, very good question. Typically, that is going to be, I would say, once you get through the vendor selection process, you're probably looking at a 30 to 60 day cycle. And that's going to be based upon your team and your managed partner's team going through, looking at your patient population, getting your patients set up. And it's often a function of your own staffing. Excuse me. Um, the vendor selection process, though, you've got to add time onto that. And as I mentioned, you really want to make sure you're working with a good partner, someone who has a long track record, has great customer service. And but really, if you're looking at vendor selection and program implementation, 90 days, 3 months to 4 months is probably realistic. That includes all of the decisions that need to be made, bringing in your clinical team, et cetera.
Another question says, if a patient was having technical difficulties with their equipment, who would they reach out to, and how would they go about getting it fixed if it needed repairs?
Yeah, that's a terrific question, and that comes up a lot. So that all depends on how you have set things up. If you have set it up such that your own staff is responsible for working with an equipment provider to get things sent out, then your staff is going to be responsible. And most people absolutely don't want that. If you're working with a managed service provider like GPT, the GPT is responsible for all of that. There's no upfront cost, and there's no additional cost if something happens and the device is broken or stops working. In that case, the patient would simply call GPT. GPT will ship them a new device. And that is, I mean, I think that is best practice because it's the most scalable way. Most practices are not experts at logistics and handling and tracking shipping. And these devices do break, they do wear out. and you want a partner who handles all of that for you. And that should be part of a service level agreement when you're doing vendor analysis. If a patient has an issue with a device, how quickly will there be follow up when they call customer service? Is there data coming in from your vendor partner on how many patients and customer support calls came in last month? That's the best situation for a practice or a hospital, but it really depends on how you set it up.
Perfect. The next comment says, where does one find the best evidence of physician acceptance of the value of RPM?
That is a very good question too. Um, I would refer to the studies within the specialties. And what we find is that physicians, I was at HIMSS last week, and Stanford Health had done a big study on RPM and found that it was very effective. And they looked at actually oncology and rheumatology as conditions. And the data is very compelling. So taking it to a physician and showing him or her the results in terms of compliance, uh, reduced exacerbations, reduced trips to the ER within their specialty is really is the best way, because that data is what proves that it works, and it is very compelling. The next issue for physicians is this going to be a giant headache? Am I going to have a bunch of data to deal with? Per the earlier question, what happens if somebody's device breaks? I don't want someone calling me, saying that I need to ship them a new weight scale. So there is that operational and logistics side of things. Clinical data, operational and logistics plan, and then, of course, the financial model. And when you are thinking about a program, I would encourage you to look at a managed services provider, because really those are the models that are most successful. A managed service provider like GPT should be able to bring all of those components to the table and meet with your team, whether it's the clinical team, the practice team, or whomever, answer all their questions and help you build out a program. That's that part of that 90-day cycle. And what we find is that once physicians see the data, once they understand that these programs which really benefit patients, can be launched with sort of minimal impact to their staff, and even better, they are revenue generators for their practice, there actually tends to be pretty good buy-in.
Thank you for that. The next question said, which I think you've already answered. Let me go. It says, this is an excellent example of value-based care. So CMS has a sort of bundled care model as their service delivery system, question mark?
Yes, and that is a very astute observation. So as we all know, fee-for-service is slowly but surely giving way to value-based care. Value-based care is achieved in one sense largely through migrating away from episodic care to longitudinal care, so that exacerbations and acute episodes for these chronic patients are reduced. RPM is a key to moving toward value-based care. Absolutely. And that is why CMS is supporting it. That's why you see FQHCs and RHCs now being reimbursed. That's why you see a financial structure out there that enables third-party managed service companies to come in and do this, make a profit, and still return money to the practice. That's not all accidental. That is a financial calculation that takes into account from CMS that the end result is there's more money saved than spent. So this is a crucial part of value-based care, in that it moves toward longitudinal care and it reduces care cost. And being kind of a tech guy, I think it's very exciting that what we're really seeing here is the use of technology and cloud-based approaches in a way that we've seen in lots of other parts of the economy where it seemed like there's an intractable problem. How can you possibly do more with less? Well, the internet and secure data management and scalable communications makes it possible. And this is really one of the first, I think, and best and early cases of what I would call successfully hacking healthcare, where we've really found a way to bring technology and data together that really addresses and improves health outcomes and does it in a way that is more cost effective. And so you'll definitely see this as an important part of value-based care. And there's a lot more coming in that aspect, of course.
Someone said, what is the best size of a pilot? Is one
Hmm.
part. And the second question is, can you please clarify how the program can be set up at no cost to me?
Absolutely. Yeah, a pilot, it varies depending on your situation. Small, excuse me, small practices, small clinics, probably 25 to 50 people. Larger clinics and practices, maybe more. Um, if you have an acute care at home program, which is part of value-based care, that's often a very good way to migrate people into remote patient monitoring. Typically, those acute care at home programs, which are getting a lot of funding, they include remote patient monitoring, but only for a short period of time. But if those patients are chronic care patients, and many of them are, then you can just migrate them to an ongoing RPM program. And so that's then sort of a subset of what you might be doing within your hospital at home program. So I would say anywhere from 25 to 50 for smaller practices, and then more for larger practices. And then also as a component of hospital at home, right? I mean, if somebody has say a cardiology practice, and that is obviously a chronic condition, there might be 1,000 patients in that practice. Every single one of those patients should be on this program. Every single one of those patients will benefit, and every one of those patients could be generating an additional $50, $75 a month for that practice. To answer the question about no upfront cost in the GPT program, GPT will GPT covers the cost of the devices. GPT covers the cost of the shipping and setup. GPT will then, after 90 days, when the patient is up and running, GPT will take the cost out of the reimbursement to cover the devices. And then after 90 days, the practice will start receiving payments. So you could go to a practice and say, well, if you have 100 patients and you've got these devices that cost $100, $150, you can pay for all of those up front and you can start receiving reimbursement immediately. But if you don't want to spend that money up front, let us send it out. Let us get it all set up. We'll start sending you from day one patient data and records and so forth. And then after 90 days, we'll start sending you the reimbursements, because then the cost has been covered. Does that answer that question?
Yes. There's one last question. I think we answered the other one already, the other two, but I know it's 12:31. So again, just for those that need to hop off, thank you for joining us. We will send the documentation and the billing guide to all attendees via email. And then when ready, we will post the webinar as well, the recording. So just for time wise, the last question says, how long does the charge last on the wearables and how long does it take to charge?
That's a good question. It depends on the wearable. It's typically going to be, I have one myself. It lasts for 3 to 5 days. Kind of depends on how often it's used.
And I think the last one you actually did answer already, but it just says, in what condition or diagnosis is the case for RPM best established?
Well, that's a good question. Again, I would refer to the literature, and the literature is really focused on the conditions that have the largest impact, right? So you see that for congestive heart failure and for diabetes. And I'm not a researcher. I just want to be clear about that. And you'll find most of the data is about those, but that's because those are the conditions where there's the largest opportunity to have an impact. However, I think really all chronic conditions can benefit, and that's why you see a fairly long list of conditions that are included.
Perfect. Thank you so much, Boyd. Thank you all again for attending today's webinar. We hope this was of benefit to you all and you've learned something new. Again, feel free to reach out to us at info@gpth.org for additional questions. And again, we will send out the materials to all those attendees as soon as we can this week. Thank you so much for your time.
Thank you, everybody, and thanks for bearing with me as I was coughing along. Thank
You did
you.
a fantastic job. Thank you all.
Thank you.
Have a great day.